of the heart team approach to delivery of care, specifically enabling us to work with our cardiology colleagues, our electrophysiologists, on how to be able to provide better care with patients with atrial fibrillation. So this is great, and we much appreciate the presentation. We're going to move forward. Again, I want to remind everyone of the great keynote speech that's going to be occurring at 12:45. I want to make sure everybody is aware of that. There's going to be a great keynote speaker, and we'll keep it suspenseful until it actually occurs. But moving forward, we will have basically the master sessions continuing. In the cardiac track, we'll go right into the cardiac master session 2B, which is on mitral and tricuspid valve. It will be moderated by Nicholas Bonaris and Sahin Saneh. And then the thoracic track, we'll go into thoracic master session 2B, which will be a combined ISMICS and the European Society of Thoracic Surgery, moderated by the president of the Society of Thoracic Surgery, Dr. Alessandro Brunelli, and Abbas and Jens Jukert. We are going now to let the moderators take it away, and we'll see you back here shortly. Enjoy the session.
Well, thank you to our live studio hosts. Welcome to Cardiac Masters Session 2B, Mitral and Tricuspid Valve. I'm Nicholas Bonaris from the Medical University of Innsbruck in Austria, and I'm joined here by Dr. Sahin Saneh of Acıbadem Maslak Hospital from Turkey, who will be co-moderating this session with me. Dr. Saneh, why don't you go ahead and tell the viewers what we have in store for them?
Thank you, Dr. Bonaris. It will be my pleasure. We are going to get started with the first segment of the session, which will feature 2 live-in-a-box presentations, then an abstract presentation followed by a group discussion. Following the first group discussion, we will have 3 invited lectures, actually. After all 3 presentations, we will have another group discussion. We encourage your participation. Please use the Q&A window to the right of your screen to ask your questions as we go along. And now our first live-in-a-box presentation is titled Minimally Invasive On-Pump Beating Heart Surgical Tricuspid Valve Repair in a Redo Setting by Jörg Kempfert of German Heart Center from Berlin. Dr. Kempfert, please.
Dear colleague, it's my pleasure to share with you a case of minimally invasive beating heart tricuspid valve repair in a redo setting. So these are my disclosures. So let's get started with the case. Let's have a look on the baseline characteristics. So this is a 82-year-old female patient, obviously high risk, status post-CABG. And after some discussion within a heart team, we decided to go for a minimally invasive tricuspid repair procedure using a beating heart endoscopic technique. Here you can see the preoperative echocardiography focusing on the right side. You can see a significant enlargement of the tricuspid annulus as well as enlargement of the right ventricle, and obviously a significant enlargement of the right atrium. The same picture in 3D, mild MR only, but again, severe tricuspid regurgitation due to annular dilatation with a gap in between the leaflets. Obviously, she has a hepatic vein flow reversal, which is explaining also the symptoms. And here you can see a patent bypass graft on the circumflex, and other than that, there's no need for any additional coronary intervention. So for all our minimal invasive procedure, especially in a redo setting, we would like to do a preoperative CT-based planning. You can see here a 3D reconstruction of the chest, and obviously fourth intercostal access would give you a very good access to the right atrium. On the other side, you can see the femoral vessels. There's quite some kinking on the left side, which is why we decided to go for the arterial calendar on the right side and the vein on the left groin. In addition, we are going to use a jugular vein for a bicaval drainage. As mentioned, we're going to perform this procedure on pump, obviously, but beating heart, so no need for cardioplegic arrest. Other than that, we use a 3D endoscopic setup. Here you can see the puncture of the left-sided groin for venous cannula, which is secured by compression suture, and then puncturing of the right femoral artery, which is then going to be pre-closed with 2 ProGlide devices, and then the 16 French arterial cannula is inserted in a standard fashion. And obviously, it's very important to monitor the guide wires in X-plane TEE. So once the heparin is in, we can then start the perfusion. We would use a DO2 guided perfusion strategy, which is usually allow you to reduce the flow slightly, which is especially important if we do not have the option to snare the cable veins. So the surgical access itself is a 3 centimeter incision in a submammary fold or in a parareolar fashion in male. Then it's obviously a non-rib spreading approach, as we're only going to use it as a working port, and the visualization is performed through a 3D 30-degree endoscope. After some poking, which is controlled with TEE, you can identify the optimal entry site to the right atrium, and then you open the right atrium together with the pericardium. So there's no need for any dissection of the tissue. With the help of a drain, suction is inserted and positions in the coronary sinus, which should give you an adequate field of view. Then with the help of the USB retractor, you can nicely expose the tricuspid in a beating heart fashion. Some additional traction sutures are sometimes required. And then you can get a beautiful access to the tricuspid valve itself. And you have noticed that there's no need to actually occlude the cable veins. So it is important for the perfusionist to maintain the optimal suction level, to not have too much air coming into the reservoir, on the other hand, not to flood your surgical field. So the pathology of the tricuspid valve in this case is pretty much standard. So it's a significant enlargement of the annulus itself. There's no sign of any extra leaflet pathologies. This is a classic sizer. In this case, we're going to use a semi-rigid physio tricuspid ring, and the 32 seems to be quite appropriate. Now, the ring implantation is pretty much standard, interrupted, non-pledged supported use stitches. They usually start at the level of the anterior leaflet, then followed by the posterior one, and then the last step, position the sutures in the septal part. And one potential advantage of this beating heart technique is that you can early recognize potential AV block, and then could take out this suture that might have caused it. With the help of the CTSNet device, the ring is secured at the annular level, and then with a brief water test indicating quite promising valve geometry, the valve repair part is already done. So in the next step, you would then position a pacemaker through the jugular vein under endoscopic vision through the valve into the right ventricle, and then you would close the right atrium together with the pericardium. Then you can wean off pump, withdraw the cannulas, and then secure the venous side with a compression suture, and the arterial side obviously with a ProGlide system. And with that, you can see the changes from the pre to the post-operative echo, especially the right heart dimensions showed significant improvement. So there was a significant decrease in the end diastolic volume, as well, obviously, as in the stroke volume. If you can see on the color-coded echo here, there's a trivial residual tricuspid regurg only. The mitral stayed in mild regurg as preoperatively, and there was preserved right ventricular function. The procedure time was slightly less than 2 hours skin-skin. CBB time 70 minutes. Patient was extubated a couple of hours after the procedure and had an ICU stay of 1 day only. On the 3D, you can see that this is the usual picture after tricuspid valve repair, slightly decreased right ventricular function than preoperatively. But in this case, we're quite lucky that no inotropic support was required. And with that, I would like to thank you for your attention and looking forward to the discussion.
Well, thank you, Dr. Kempfert. Our next live in the box presentation will be presented by Leonard Conradi from the University Heart Center in Hamburg, Germany. and is titled TMVI tendine in major annular calcifications. Dr. Conradi, the stage is yours.
Hello, everyone. This is a live in-box case of a tendine in MAC procedure. This patient has severe secondary mitral regurgitation with severe calcification of the predominantly posterior mitral annulus. Access is transapical, so a few centimeters skin incision and access through typically the fifth or sixth intercostal space. Typically, for tendines, we're not using epicardial pacemaker leads, but we will need it in this particular procedure. This patient did not have a cardiac operation before, so I'm opening the pericardium. And this is the finger poke test in order to make sure there's an adequate transventricular trajectory to the mitral annulus. 2 felt-pleated U stitches, 90 degrees opposing, are more than enough to secure the apical access. Typically, the first one is done in parallel to the ribs, whereas the second one goes in 90-degree angle. And once you're finished with this and secure the sutures with tourniquets and felt-pledgets, I'm affixing the epicardial pacemaker lead, such as we were doing when we're still doing transapical TAVRs. Groin instrumentation is rather straightforward. This is a bifemoral arterial access, 2 long arterial sheaths. One will measure the pressure in the aortic root with a pigtail catheter, and another one in the left ventricle for online trans-LVOT gradient assessment. There is a 6 or 7 French venous sheath as well, in order to allow for a right heart study, which we typically do before as well as after the procedure to assess the implant success. This is a transulnar 6 French sheath to insert a sentinel filter device in a bovine arch. So it's a distal filter deployment first. Here goes the first distal filter in the left common carotid, and here is the proximal filter in the brachiocephalic trunk. You can already appreciate the wire and pigtail in the aortic arch. Next step then would be, as I said, a right heart study with cardiac index assessment. This is not part of the core procedure, but we still find value in this to have a baseline value as well as implant after the implant. You can easily on the fluoroscopy see the severe mitral annular calcification. Next step, puncture of the left ventricle and following up with a floppy J wire. In the X-plane as well as fluor, you're going to have to guide the wire through the subvalvular apparatus into the left atrium. And of course, you will have to make sure there's no entanglement in the left ventricular chamber before you follow up with the large bore tendine sheath. This is done by a flossing, so-called flossing maneuver with a PA catheter with inflated balloon advance and retract in order to make sure there's a free route. Now this step is special and not typically done. We're inserting a 14 French sheath into the left ventricle and across the mitral annulus in order to be able to predilate this valve. This is not a predilatation to predilate the annulus, which can be rather dangerous and is not to be advised, but rather to displace calcific spicules on the valves and on the leaflets themselves. It's a 28 millimeter true dilatation balloon, and for this we need a brief phase of rapid pacing. And next step would be insertion of the tendine delivery sheath with its inflatable dilator, careful rotating movements in order to pass the myocardial wall, and then fluoroscopy guided advancement of the sheath across the mitral annulus into the left atrium. From here on, it's no longer an over-the-wire procedure. Typically, patients are well stable during this procedure. You have to take care that the sheath is central within the annulus. And on the bottom left panel, you can see the X-plane with the valve being extruded now from the sheath, just atrial from the mitral annulus. And you'll still want to make sure that it's centralized in the left lower hand 3D en face view in order not to pin open mitral valve leaflets to create even more MR than there already is. You know that the tendine stent is asymmetric. It seems D-shaped in the AP dimension, which also helps in axial alignment or axial or rotation alignment rather. And then once the valve, the future valve outflow portion of the stent is free, the deployment has basically been accomplished. Next step would be to take traction, upper left hand panel on the tether extension through the catheter. And now the implant catheter can be removed and the purse strings or U-stitches are being closed on the apex, as you can see right now. Within this step, the second operator closely watches echo in order not to displace the valve. This is the apical pad or fixation pad, which will rest on the epimyocardial surface of the heart. There's a tilt function. If you want to pass a mini incision like this one, you will have to use it. And then there's a regulator on the valve position or the pad positioning tool in order to adjust tension on the tether. Once you have good apposition and good tether tensioning, you can assess the result. This patient had a pre-existent mild aortic regurgitation, so this is not new. There was rule out of paravalvular leakage. And then if that is confirmed, next step would be to release the tether, to pin the tether and make it, fix it in that position. And then in just a second, remove the pad positioning tool by opening its two arms, as you can see right here, and removal through that mini thoracotomy. Last step would be to shorten the tether, tie your purse strings, and then close the thoracic access. Before we do that, we remove obviously the claret or the sentinel filter device before we apply protomine. This is the final echo image with excellent sealing, good opening. There was a transvalvular gradient of just 3 millimeters of mercury. This is what the surgical field looks like. I tend to close the pericardium, especially in slender patients, in order to shield off that foreign body epicardial pad from the thoracic wall. And that's basically it. Removal of the soft tissue protector and layer closure of the access. Patients are typically extubated right afterwards in the hybrid OR and then transferred to the intensive care unit. And this is basically all it takes for a Tendyne procedure. And with that, I would like to thank you for your attention.
Thank you, Dr. Conradi. It was an excellent talk. Our next presentation is an abstract, actually, with the title Minimally Invasive Surgery versus Sternotomy Approach in Mitral Valve Redo. It will be presented by Dr. Eric Curastura from Torino, Italy. Dr. Stura, the podium is yours.
Good morning, everyone. I'm Eric Curastura from Città della Salute e della Scienza Hospital of Turin, Italy. Today, I'm talking about minimally invasive surgery versus sternotomy approach in mitral valve redo. I have no disclosure to share. Reoperation in cardiac surgery have been increasing in the last years. In fact, STS database reported that more than 10% of cardiac surgery procedures are reoperation. And mitral valve redo performed through standard sternotomy is associated with significant morbidity and mortality due to sternal re-entry and related extensive lysis of adhesion. Then, in these cases, minimally invasive surgery could be an alternative approach. In fact, in the general population, minimally invasive approach had reported several advantages compared to sternotomy, but in the subgroup of high-risk patients like redo, it could be an additional advantage. From January 2006 to January 2019, about 800 consecutive patients underwent mitral valve surgery in our department. Of these, 24% were redo. 134 patients were operated through standard sternotomy, and about 300 through minimally invasive approach. The two groups did not report significant differences in preoperative characteristics, except for a higher Euroscore in the sternotomy group due to a higher pulmonary pressure and a higher number of urgencies. And the cannulation and clamping strategy was different in the two groups. In minimally invasive surgery, the preferred setting was peripheral cannulation with endoclamp in about 80%. Peripheral with transthoracic clamp was used in 7% and with endodirect in 5%. And in the sternotomy group was preferred the central cannulation, while peripheral cannulation was used in only 10%. Aortic close clamp time was significantly longer in the sternotomy group, while there was no significant difference in cardiopulmonary bypass time. In the postoperative period, minimally invasive surgery reported a significant reduction of intubation time and ICU stay. And in the postoperative outcomes, minimally invasive surgery reported fewer complications rate and significant reduction of blood transfusion, tracheostomy, and new onset of atrial fibrillation. And in the follow-up, minimally invasive surgery reported a higher freedom from reoperation and a higher survival rate. Then we can conclude that minimally invasive surgery allows to avoid the complication of sternal re-entry and related extensive lysis of adhesion. It allows a good mitral valve exposure even in the redo and reported several advantages, including fewer blood transfusion, a reduction of ventilation time, and a shorter ICU stay. And at the follow-up reported a higher freedom from reoperation and a higher survival rate. Then, therefore, in our practice, it has become the standard of care in mitral valve redo. Thank you for your attention.
Great. Thank you, Dr. Kurastura, for this excellent presentation, for giving us data. We would like now to open this up to the attendees for discussion. A reminder for all, please be sure you're typing your questions into the Q&A box on the right of your screen so that we can take into consideration for the discussion. Now, let's start with a couple of minutes. We'll start with Jörg Kempfert. There were some questions about the cannula. Can you please elaborate a little bit on the venous cannula and what is the amount of patients where you need to go back and reposition the cannula because you're having air problems?
Yeah, thanks. Very good question. So in regard to the venous cannula in the jugular vein, it's very easy. It's 16 French for female and 18 for male. In all these patients, we use a 25 standard multi-stage cannula from the femoral vein. Also, obviously, there is the option to use dual-stage cannulas. So those lungs cannulas that only have holes in the SVC and IVC and no holes at the right atrium. And this would be our standard setup for a non-redo tricuspid surgery. But in the redo setting, as we want to avoid kind of encircling the cable veins, which is obviously very kind of tricky and cumbersome, we opt for jugular and femoral vein cannulation. Air block is usually not a problem. As long as you pull back your venous cannula below kind of the site, then you will not have problems. If you really are worried, there obviously is the option to use Fogarty or any other balloon catheters to occlude the cable veins, but usually it's not required.
And Jörg, maybe a second question to you is about the cannulation strategy. During the punction and the placement of the cannula, do you use ultrasound and T guidance for this step?
Good question. So honestly, I have to admit, I do not use ultrasound. I know that especially in the US, it is becoming extremely popular to do any kind of puncture with the ultrasound. I'm not very good with it. However, what we do is we do a CT scan in every single patient, and then you have your anatomical landmarks, and then you know whether or not you face a high bifurcation on one or the other side, and obviously you adapt your strategy in regard to that. And it's 2 proglides. If these 2 proglides fail, a good trick is to rewire the cannula before pulling it out. If there's still some oozing, you can bail out with an 8 French angioseal. And if there's a real kind of messy bleeding, so pulsatile bleeding, one good trick is to use a Manta device for bailout after failed ProGlide devices.
Okay, perfect. Thank you. That is all the time we have left for the group discussion. Thank you to the presenters for being here with us today. And now we are going to move into section 2 of cardiac session. Our first presentation within this segment is titled How to do mitral clip step by step, to be presented by Simon Sunderman of the Deutsches Herzzentrum Berlin. Dr. Sunderman, please, the podium is yours.
Good morning, ladies and gentlemen. First, I want to thank the Society for inviting me to give this talk today. My name is Simon Sunderman. I'm a cardiac surgeon from Berlin, and I was asked to talk about the mitral clip therapy, how to do it step by step. So let's directly step into the procedure. First step, of course, is the venous puncture. So we do a regular venous puncture on the right groin. We introduce a 6 French sheath. We do a skin incision of around 1.5 centimeters around the sheath to be able to implant the guide system later on. And we just place a U-suture around the puncture. The next step is the preparation of the transeptal puncture. So a wire is coming with the transeptal sheath that's placed in the superior vena cava. And then we bend the transeptal puncture needle to 90 degrees. It's very important to leave the sole inside because otherwise kinks can happen. And then we introduce the needle until the tip is at the end of the introduction sheath, but not outside. And then you have to turn the needle and also the sheath in the same directions to around 2 to 5 o'clock. And then you have a good position to start the transeptal puncture. You then slightly pull back the whole system. Here it jumps into the fossa. And the next step is to find the right spot for the transeptal puncture. So you move the needle and the sheath within the left atrium, you pull it back, you turn it posterior, anterior until you have a good position, posterior enough not to puncture the aorta, and high enough above the mitral valve. You should have a distance of 4 to 5 centimeters above the coaptation line. And as a next step, if you have this good position, the transeptal puncture can be performed. You slightly push against the sheath to hold it in position, and then with a very short push, the transeptal needle is pushed through the septum, followed by the introduction sheath. This step is followed by the placement of a guide wire in the pulmonary vein. A soft wire is inserted first, followed by the sheath, followed by an amplat superstiff, which is left in place in the pulmonary veins. This is the guiding structure then for the guide catheter of the mitral clip system. So this is introduced as a next step. So the guide system is forwarded until the septum, and with a slight push of the dilator is brought to the left atrium until it is visible in the left atrium. If you rotate it a little bit, it's easier to bring it to the left side. And if you have a stable position, have the system stabilized in a safe position, then you can pull back the dilator and the guide wire, but only if you're sure that you have a stable position. With this stable position, that the mitral clip can be introduced, the clip is forwarded until it's in the left atrium, just coming out a little bit out of the guide wire. Next step is the positioning of the clip and the guidance towards the mitral valve. For that, the crista has to be located and the clip has to be guided around the crista. If you found a proper position above the mitral valve, the alignment of the clip is of course the next step. We want to have a position of a 12-6 orientation in the surgical view. So if you have your alignment, you want to have the clip a little bit more lateral, then you have just to push on the system. If you want to have the other direction to go more medial, then you just have to pull on the device. If this is not sufficient or not possible, your anesthesiologist can help a lot. So you can ask him to perform some respiratory maneuvers. So he can, for example, give an expiratory hold, then the clip will come more medial. If he does an inspiratory hold, the clip will come more lateral. And then you can pass the valve. You just go with the open arms through the valve. You have to reassess the clip position because by touching the leaflets, of course, the alignment of the clip can change. So be sure and reassess the clip assessment, the clip position after passing the valve. If you have a proper position, you can start the placement of the clip. So and the grasping of the leaflets. So you slightly pull on the whole system until the clip is located just below the leaflets, until the leaflets are located on the clip arms, and then you can lower the grippers. And if you have a safe grasp of the leaflets, then you can close the device, and then you should release tension, keep the device just in a very stable position for assessment of the valve. You do an echocardiography, you assess the remaining regurgitation, and also very important, you assess if there's a relevant transvalvular gradient. If you see that you have already an relevant remaining regurgitation, but also a relevant gradient through the valve, then you should think about reposition the clip, and then the next step is to release the first clip. Both lines, the gripper line, the lock line, are released. Only the lock line is pulled back. Then you check the safe position of the clip. You do the final arm angle test at this point of time. Then you release the clip. You check the safe position again, and then you pull the gripper line, which is till now the last safety net to hold the clip. If you're happy with the first clip, you can pull out the whole delivery system, but just leave the guide catheter in. And for the second clip, the placement of the second clip, if necessary, is even a little bit easier, because you have the first clip as a guiding structure. Very important to pass the valve with the second clip with closed arms, because otherwise you have the danger of entanglement within the first clip. And it's also advised to pass the valve with the second clip after alignment of the clip arms above the valve, and then to reopen the arms after passing the first clip under the valve. This is the whole procedure, placement of a second clip after a first clip. I hope I could show you that a mitral clip procedure is a doable procedure, also of course by surgeons, and I think it's very important to get involved in these procedures, as other transcatheter mitral valve procedures are on a rise, and we should just include these procedures in our armamentarium of minimal invasive mitral valve procedures. With that, I thank you very much again for your attention, and I hope you enjoy the rest of the meeting. Thank you very much.
Thank you, Dr. Zinderman. Very important technical issues. Thank you. Our next presentation will be presented by our past president, Anson Chung of the University of British Columbia and St. Paul's Hospital in Vancouver in Canada. And it's titled Update on TMVI Devices in Clinical Use. Anson, the stage is yours.
I'm Anson Chung from Vancouver. Would like to give you an update on TMVI devices. These are my disclosures. There are many devices in different stages of development. Many of them has been implanted into human. I do not have time today to discuss every single one of them. However, I'll give you some highlights. Abbott 10-dime system is one of the forerunner, with over 600 implants now worldwide. It is delivered through an apical delivering system of 36 French size. It is anchored cell by an apical tether with a ventricular pad that is attached outside of the left ventricle. Two ongoing trials at the present time, with the Resolve MR and the Summit IDE trials ongoing. The first 100 patients with 2 years follow-up results has been reported by Posteragia. They reported a 97% implant success rate with very low perioperative complication rate, the 6% 30-day mortality, and very low re-intervention required for the mitral valve prosthesis. There's significant improvement in quality of life in NYHA class reduction and reduction in rehospitalization secondary to heart failure. The second valve is the Medtronic Intrepid. It has a unique design. It has an outer valve stand that is attached to the annulus, and the inner valve stand of 27 millimeter, that is the working valve. It's also an apical system, 35 French size. The first 50 patients' results has been reported. With a mean age of 73, 6.4% on average STS scores, with an implant success rate of 96%, with a 6% 30-day mortality. There's an ongoing trial called Apollo. It has 2 arms. The first arm is randomized to mitral valve surgery. A second arm for patient who is ineligible for surgery will also include a group of patients are very difficult to treat with mitral annular calcifications. Now, more than 65 sites are activated with 200 patients approved for the device. However, the actual number of patient implants has not been reported. It's also in development a transfemoral transeptal intrepid device. The third valve is the Neovasc Tiara device. It had 2 sizes, a 35 and 40 millimeter with a D-shaped device. It uses 3 subannular anchors, 2 anteriorly, 1 posteriorly, to anchor itself to the annulus. It has actually had the longest surviving patient with TMVI devices, over 7 years, and doing quite well. 2 trials, the TR1 has been finished, and with patient being followed up at the present time. And a European trial, TR2, for CE mark approval has been ongoing. 34 implants thus far. Due to COVID, the trial has been put on hold. 93% implant success rate with a 30-day mortality over 10%. There's a great resolution of mitral valve regurgitation and improvement in MRJ classes. There is a transfemoral transeptal delivering system mated to a lower profile valve that could accommodate more patients. Preclinical implant has been successful. The next valve is the Edwards Evoque, a transfemoral transeptal 28 French delivering system with 2 valve sizes. This is the improved version of the cardiac AQ valve. It has 9 ventricular anchors that attach itself to the mitral valve leaflets and caudides. The early result of the first 14 patients has been reported with 93% implant success rate, with a 7% mortality and 40% stroke rate risk. The next Edwards valve is the SAPIEN M3 system. It has 2 integral parts, a docking system subannularly and a modified SAPIEN 3 valve that we use daily for our TAVR. This is one of our early cases in Vancouver, showing the subannular dock and a SAPIEN 3-like device inserted into it. The first 45 patient results have been reported with an 89% implant success rate, with 1 single patient mortality and 3 patients had suffered from a stroke. 1 patient had late mitral valve surgery due to valve dehiscence. There is not as good as a reduction in mitral regurgitation, however, still quite good at 30 days. There is a trial called Encircle, is ongoing, intended to recruit 250 patients. The next valve is the Abbott Xavier valve. It has a double disc structure using axial compression forces to anchor itself onto the annulus. It's transfemoral transeptal with a single valve size of 36 millimeters at the present time. The first in man cases is performed by Thomas Modine in France, and subsequent 2 other cases has been successfully implanted with 100% success in implant rate and no 30-day or 6 months mortality. In conclusion, TMVI is a very effective and repeatable procedure for mitral regurgitation. The results are improving compared to the early days, and more promising results with newer version of the devices and more experiences. In the future, TMVI will become one of the important tools in treating mitral regurgitation in less invasive method.
And thank you, Dr. Cheng. It was an excellent talk, as always. Our next presentation is going to be the last one, actually, in the session, and the group discussion will follow. As a reminder, please be sure you are typing in your Q&A as we go in the box on your right of your screen. Our final presentation in this session is titled Transcatheter Tricuspid Wire Replacement Devices Update, V9 Wires, to be presented by Dr. Lucien Lazonchi from University of South Florida. Dr. Lazonchi, the podium is yours, please.
Hello there. My name is Lucien Lazonchi. I'm the Chief of Cardiothoracic Surgery, University of South Florida, and Tampa General Hospital. I'm going to talk today about the V9 valve. These are my disclosures. I'm one of the founders of the V9 company. As you all know, tricuspid valve disease is prevalent and largely untreated. Patients with tricuspid regurgitation have a poor life expectancy. In this article from JACC in 2004, the patient with severe tricuspid regurgitation have only 60% one-year survival. Surgery is only currently approved treatment for this disease, has high operative mortality reported between 10 and 30%, and worse outcomes than any other valve surgery. There's clearly an unmet need for this population. Transcatheter repair devices have reported significant reduction in tricuspid regurgitation. TriClip reported a 6-month data at the Euro PCR London valves, but over a third of the patients have severe residual TR. Pascal device reported their 30-day data at TVT, and with over 15% of patients have 3+ residual TR. The Cardioband also published their results and reporting over 6-month results, reporting over a quarter of their patients have a severe to torrential TR. V9 has an interesting solution of side delivery and the ability to deliver large valve sizes into a relatively small catheter and be able to treat a broad range of annulus sizes. It can be achieved through a simple controlled femoral delivery with fluoroscopic guidance, a short learning curve, and procedure times. The valve size, design, and shape matches the tricuspid valve anatomy. The valve is repositionable and retrievable. Here's an illustration of the valve. This is the atrial side of it, and this is the ventricular side. On the atrial side, it has a larger free wall cuff with a shorter septal cuff to avoid compression of the septum, and an area that can be popped to allow some regurgitation if there's a afterload mismatch. The securement mechanism is comprised of an RVOT tab that ends up right underneath the pulmonary valve, and a proximal tab or loop which can be reduced, cinched, and achieve a ventricular perimeter reduction. Delivery system has a delivery catheter and a control catheter that's provided with a yoke that controls and delivers the valve. This is an illustration of the procedure. The tricuspid valve is crossed with the soft wire into the pulmonary artery. The valve is expressed from the delivery catheter and is very easily controlled and precisely controlled with a control catheter, and which also controls the RVOT tab right here. This is placed over the anterior leaflet of the tricuspid valve, and once the valve is fully exposed and from the delivery catheter, a series of strings are used to cinch and deflect the ventricular tab and allow the valve to change its perimeter and be seated well onto the tricuspid valve annulus. After that, once in a position, the tab is released and the valve secured in place. These are 70 patients in a cohort of a CT analysis with severe tricuspid valve regurgitation, and these are the annular sizes. The current devices have several sizes, up to 50 millimeter in diameter, and both Medtronic Intrepid and Edwards Evoque. VDAN can cover the other third of the patients with sizes up to 70 millimeter in diameter. This is a demonstration of the valve retrievability and an illustration how such a large valve, 60 millimeter valve, can be delivered and retrieved with a relatively small catheter. There are several implant concerns in the tricuspid position. Those are related to conduction disturbances, ventricular injury, right coronary compression, and sometimes maybe not good to eliminate the tricuspid regurgitation. And for that reason, a pop-off can be created and later closed if needed. But all the other concerns are addressed by mainly these attributes of the valve in the top of the table. The fact that the valve matches anatomy, does not oversize in the direction on the septum, does not interfere with the septum, its cuff, and valve has a short height. As well as preclinical testing showed that delivery system is capable to access, deliver, reposition, and secure the valve. The chronic animal studies showed excellent function and as well bioresponse. This is complete ingrowth of the atrial cuff. This is an illustration of the RVOT tab. And furthermore, the early efficiency study, early feasibility study is currently being submitted. Regulatory-wise, VDAN obtained the breakthrough device designation as last year. Currently, since March 2021, has Medicare coverage because of this new innovative technology pathways that was created. In summary, tricuspid regurgitation is prevalent and patients have worse survival than any other valves. Treatment challenges is related to anatomy, size, conduction system. The site delivery is rethinking, and I could say in this conference, reimagined the transcatheter valve replacement. Has the ability to deliver large valves compared to the diameter of the delivery catheter and treat a large range of annular sizes. The valve allows for simple control femoral delivery with fluoroscopic guidance and can be used for other heart valves as well. The valve design and shape respects patient's anatomy and facilitates repositioning and retrievability. Finally, this focused regulatory strategy in the US and EU through the breakthrough device designation provides an expedited path for patients to access promising new technologies. Thank you. I'll be happy to take any questions.
Thank you, Dr. Lozansky. Very important presentation. Thank you. I would now like to open this up to the attendees for the discussion. Before we start, one reminder to all of the attendees, please be sure you're typing your questions into the Q&A box on the right of your screen. And a second reminder, there was a question also on the ISMICS on-demand library is already integrated into the agenda of the virtual meeting portal. So if you click view the program button, then you can scroll through the agenda and click on the sessions to view the videos. Having said that, I think we are very keen to start the discussion. Until we're waiting for questions coming in, I have a question for both two first presenters, Dr. Zündermann and Dr. Chang. So we know that we have also to treat, which are difficult to treat surgically, like the functional mitral regurgitation. And there has been a huge adoption of mitral clipping in this area. So where do you think that TMVI, as presented by Chang, 4 different devices and a lot of them in the pipeline, will compete with edge-to-edge interventional repair, to which extent? And who will be the winner? I would start with Dr. Sundermann.
Yeah, thank you very much. Very good questions. Of course, this is a very important topic. So when we started our MitraClip program, we only choose, of course, the functional MR patients. These are the patients that we found in our surgical department, because it's very difficult to get patients referred, and we saw that we can have some satisfying results, but of course not for every patient. And we saw that patients with a very low ejection fraction below 25% really don't benefit for a long time. So a large part of them had a left ventricular assist device few months after the clipping. So I think these patients mainly will probably have a benefit from the implant of a valve, so transcatheter valve implantation like the 10-9 or whatever's on the horizon, and will win the race. So that's what I think.
Yeah, I don't think there's actually necessarily a winner here, either one. I don't think there's a magic bullet like TAVI, for aortic stenosis. The mitral valve pathology is so wide, with stenosis and different pathology for regurgitation. I think the repair and the implant or TMVI are actually complementary, not necessarily competing. There's also certain patients, obviously, they could cross that are in the gray zone that could use either technique. But I think there's a divergence of patients who have that TMVI is absolutely not capable because of the anatomical reason. And it's also same with the repair technique, multiple devices. So I think they are just two different tools in a toolbox. And people keep asking me, who's going to win? I think both of them is going to be winner. Depends on the the technology. I think you improve. We are in the first or second generation the TMVI devices, where let's say per se MitraClip or Pascal is already at third generation from the initial technology. So I think we are improving along the line, and I hope that definitely will be a part of the technology that could help patients.
Also, just a brief question. Thank you very much. It was an excellent talk. Which access type do you think that will survive at the end of all this mitral technology, the transapical system or transfemoral system? What do you think about that, about the future of the access for mitral, transcatheter mitrals?
There's no doubt. I think transfemoral transeptal will win eventually. I absolutely believe in that. Though you need to first prove, the device which we're going to put in, which is the valve, has to work first. So, the easiest way to get that into the patient would be apical in certain instances, in certain valves. And then once the transeptal transfemoral system are now more mature, more manipulable, and sufficient small in size, I think that they will eventually win. Absolutely no doubt. I think just needing time, I think that's where we are.
Then should we say that all the surgeons should get familiar with the transeptal approach for now?
Well, I think, you need to know both, because certain devices have no femoral access at the moment. So you have to, surgeons and or even interventional cardiologists that, should be working together to get the apical side of things working, the valve tested properly, get data on the patient who you should treat on, the durability data on those who are surviving patients. And I think once you work on that and get the femoral system developed, in the meantime, majority of the apical system out there at the moment, the company had a transfemoral transeptal system in development or already tested or had a clinical implant. So there's no doubt they're all coming along.
Okay, thank you. Thank you very much. All right, it looks like that is all we have time for this session. Thank you to all of our presenters who have joined us for this session. We are now going to turn it over to our host in the live studio, who will be with us in just a few moments. Thank you very much for all.
Thanks, Ed.
Ich wollte dir noch sagen, ich fand es wunderbar, dass du noch immer da bist.
Du kannst ja noch mal fragen, es kostet dich ja nichts, vielleicht sag ich dann ja.
Dein Herz lag neben meinem, Ich hoffe, es ist noch da, wenn du gleich aus dem Bad kommst. Alles ist jetzt möglich, du hast es in der Hand.